Imagine walking out of a hospital with a diagnosis for your child, and the doctor hands you a projected medical bill that is, literally 6 times your entire family's annual salary.
Yeah, that's just unimaginable for most of us.
Right. But for families navigating sickle cell disease in Ghana,
Yeah.
that isn't like some hypothetical worst-case scenario
Yeah.
or a bad administrative error. It is just a mathematical certainty.
And, when we talk about chronic inherited conditions, we usually focus almost entirely on the clinical
We
symptoms.
map out the physical toll.
Exactly, the physical toll on the body. But we rarely take the time to map out the financial shockwave, the kind that washes away a family's foundation, greens their savings, and just systematically removes their ability to participate in the broader economy.
Well, welcome to the deep dive. Today we are digging into an incredibly fascinating 2026 academic manuscript. It was sponsored by the Institute for Life Sciences Collaboration.
Right, and it looks specifically at the economic impact of sickle cell disease on households in Ghana.
Yeah. And our mission here isn't just to talk about the biology of a medical condition. We are here to uncover the invisible, overarching economic forces that a genetic disease basically sets loose on a family's life.
It's a really profound look at how, a microscopic change in human DNA can essentially rewrite the macroeconomic reality of an entire household.
Okay, let's unpack this. Before we get to that massive bill and all the financial data, we really have to understand why the invoice is so long in the first place.
Right. What are you actually paying for?
Yeah. What is the actual day-to-day physical reality of sickle cell disease, or SCD? Because the source makes it very clear we aren't dealing with a simple localized illness here.
No, not at all. Let's bypass the textbook jargon for a second. Fundamentally, SCD happens when the body's hemoglobin factory gets the wrong blueprint from its genetics.
Right, and hemoglobin is the protein in your red blood cells responsible for carrying oxygen.
Exactly. But with this specific genetic mutation, the body mass produces a faulty, sticky version of hemoglobin.
So instead of having nice, plump, flexible red blood cells that can easily, squeeze through tiny blood vessels to deliver that oxygen,
The cells distort.
yeah, they become rigid. They take on the shape of crescent moons, or sickles.
And that physical shape changes absolutely everything. Because they are rigid and pointed, they just don't flow smoothly through the bloodstream.
They snag on things.
Yeah, they snag on each other. They pile up and create these massive traffic jams in your blood vessels. Medical professionals refer to these microscopic traffic jams as vaso-occlusive crises, or VOCs.
A traffic jam in your veins. But instead of just making you late for work, this traffic jam means the surrounding tissues and organs are literally suffocating,
Right, they are being starved of oxygen.
which brings an intense, unimaginable level of pain, right?
Oh, absolutely. And it's not just a momentary flash of pain either. When blood flow is repeatedly blocked like this over years, it triggers a cascade of severe complications.
The source outlines some pretty brutal realities.
Yeah, things like acute chest syndrome, where the lungs are critically compromised. You see leg ulcerations, widespread organ damage.
Oh, and there's also that devastating complication splenic sequestration. I want to stop on that term because it really highlights how volatile this condition is.
It does.
What is happening mechanically in the body when that occurs?
Well, it is a life-threatening emergency where those sticky, sickled red blood cells suddenly get trapped inside the spleen.
Oh, wow.
Yeah, so the spleen acts almost like a sponge. It rapidly soaks up a massive portion of the body's total blood volume.
Your blood pressure just drops.
It plummets.
Yeah.
Dangerously fast. And without immediate medical intervention to restore that blood volume, it can be fatal in a matter of hours.
Man, it really hits home why this requires such constant vigilance. It's a lifelong multi-system disorder. Every single organ relies on blood flow, which means every organ is constantly under threat.
Right, and the global scale of this threat is staggering too. The manuscript notes that worldwide, roughly 300,000 children are born with SCD every year.
300,000.
Yeah, and due to population growth in highly affected regions, that number is actually projected to climb to 400,000 by the year 2050.
With a massively disproportionate impact on sub-Saharan Africa.
Mm.
The numbers for Ghana alone are intense. Up to 40% of the population carries the sickle cell gene.
We should clarify, though, that carrying the genetic trait is different from having the active disease.
Right, you need a copy from both parents.
Exactly. You need to inherit the mutated gene from both parents to have active SCD. But even with that clinical distinction, the actual prevalence rate of the disease in Ghana sits at about 2 to 3%.
2 to 3% of the entire population. We are talking about millions of individuals requiring intensive, complex, daily care just to survive.
Which really brings us to the core thesis of the researchers' work here. The biological toll is systemic, yes. But how does that translate into the global economy?
Yeah, reading through the source's background data, the sheer dollar amount attached to this disease is jarring.
It is.
But the researchers draw a very clear line between two types of costs, direct costs and indirect costs. Direct costs seem to be the visible tip of the iceberg, right?
Yeah, they are the receipts you hold in your hand when you walk out of the clinic. The hospital beds, the daily medications like hydroxyurea, the blood transfusions, the lab
The
tests.
stuff that's easily quantifiable.
Right. But the vast majority of the financial burden lies beneath the surface.
The invisible iceberg.
Exactly, the indirect costs. This category includes absenteeism, missing work because you or your child is in the hospital. It includes losing your job entirely due to unreliability.
Oh, and it also includes presenteeism, which is a massive drain on economic output. I want to dive into the mechanism of presenteeism for a second, because it is so insidious.
So go for it.
If I am the parent of a child with SCD, I might be up for 48 hours straight managing their pain crisis at home. I still show up to my job the next day because, well, I can't afford to be fired.
Right. You have to be there.
But I am absolutely exhausted, distracted, and prone to mistakes. I am physically present, but economically, my productivity has completely crashed.
That is a perfect illustration of how the cost bleeds outward. If you work in an informal market or in agriculture, which is highly common in many developing economies, that sheer exhaustion directly translates to a smaller harvest.
Or fewer goods sold at the market stall.
Exactly. The economic output evaporates even though you technically went to work.
The global data points they pulled to demonstrate this are just wild. In the U.S. context, the direct costs average maybe $1,200 to $1,900 a month per patient.
Which is already a lot.
Right. But the indirect costs, lost productivity averages over $7,600 annually per person.
Wow.
And the total unpaid labor losses for caregivers in one cited U.S. study exceeded $3 million. The kicker is that was a study where only 30% of the respondents were even employed.
It clearly demonstrates how a single diagnosis pulls multiple people out of the workforce. It drastically alters the trajectory of the entire household.
I do have to push back a little on the phrasing the economist used there, though. Unpaid labor losses.
Yeah, it's a bit dry.
It sounds so sterile, almost like a corporate write-off. But from the perspective of the family, you're essentially running a shadow hospital at home.
A shadow hospital. That's a great way to put it.
Right. You are administering medications, monitoring oxygen levels, tracking symptoms, managing diets. You aren't getting a paycheck for it, but the broader economy is absolutely losing out on your participation because your full-time job is keeping a loved one alive.
If we connect this to the bigger picture, that shadow hospital is a structural weight on the entire society. It is a massive diversion of human capital.
Yeah.
Take the data from Brazil that the authors highlight. Care for SCD costs Brazilian society over $413 million annually.
Unbelievable.
But the crucial detail is that over 70% of that figure is indirect costs. The shadow hospitals, the lost harvests, the presenteeism.
And the human element gets completely flattened if we only look at spreadsheets. There's a study out of Tanzania mentioned in the text that evaluates the psychosocial costs on parents.
The emotional toll.
Exactly. The constant grinding stress of managing this shadow hospital leads to severe family conflicts, high divorce rates, and even limited access to education for siblings. Every available dollar and ounce of energy is just drained by healthcare needs.
The household essentially reorients its entire existence around the disease, which sets up the core investigation of this 2026 manuscript. How does a family survive when the economic demands fundamentally outstrip their resources?
Yeah. To answer that, the researchers zoomed into a specific case study in Ghana, and the methodology here is fascinating.
It is.
They needed to figure out exactly how this impacts a Ghanaian household. So they randomly sampled 400 households at the Greater Accra Regional Hospital. To give you some context on the scale, this isn't some small neighborhood clinic.
Oh, no, definitely not.
Their outpatient department alone handles 14,000 cases a month.
So taking a sample from a hub like that provides a highly representative cross-section of the population actively navigating the healthcare system.
Right. They gathered demographic details, gender, age, urban versus rural location, and then built a multiple regression model.
Combining that with robust secondary baseline data from the Ministry of Health and the Ghana Statistical Service.
Because let's be real, trying to get an exhausted parent in a crowded hospital waiting room, someone under extreme emotional distress, to accurately calculate their long-term indirect economic losses over the past 5 years. It's nearly impossible.
Yeah, you just can't get reliable data that way. The regression model allows researchers to bypass that human error. They take the concrete demographic data and calculate the hidden financial impact mathematically.
And the numbers they uncovered are deeply unsettling. According to the baseline data used in the study, the average annual household income was roughly 16,644 Ghanaian cedis.
Okay, keep that number in mind.
Yeah, 16,000. But the average annual direct cost for an SCD patient was 85,901 cedis. Add on the indirect costs of another 11,713 cedis.
Just let those figures sit for a moment.
So what does this all mean? I really want to make sure you, the listener, grasp the scale of this disparity. The disease demands almost 100,000 cedis.
And the family only brings in 16,000.
The cost of care is roughly 6 times higher than what the average family earns in an entire year. It is a mathematical impossibility.
It absolutely guarantees catastrophic health expenditure. A family in that position is forced to sell assets, pull children out of school, or just take on ruinous debt.
There's no other way.
And the study makes a point to emphasize the macroeconomic environment complicating this even further. They included national inflation as a key variable in their analysis.
The inflation figures they cite are brutal. The paper notes that from 2018 to 2021, inflation in Ghana was relatively stable, hovering around 9.8%.
Which is manageable.
Right. But in 2022, it jumped to almost 32%. And by 2023, it spiked to an eye-watering 45.44%.
That level of inflation just vaporizes purchasing power. The regression model proved that inflation had a massive positive effect on both direct and indirect costs. It severely crippled a household's ability to cope with even the baseline expenses.
Think about the indirect costs in that environment. If transportation costs jump 45% in a single year, getting to the hospital for a routine, life-saving blood transfusion suddenly becomes a luxury.
You have to weigh it against feeding your family.
Exactly. The cost of the taxi, the cost of food while waiting all day at the clinic, the cost of mobile data to coordinate with doctors. None of that is covered by insurance, and all of it explodes under that kind of inflation.
Even with Ghana's National Health Insurance Scheme, or NHIS, which does offer a single-payer system and covers some childhood complications related to sickle cell.
It's just not enough.
The researchers conclude it is completely insufficient to alleviate this crushing burden. The NHIS might cover the hospital bed, but it doesn't cover the transportation, the lost wages, or the holistic lifelong management the disease requires.
Since the math is that broken, you have to wonder who is actually bearing the brunt of it. Does being wealthy or living near the hospital insulate you?
That is the big question.
And here's where it gets really interesting. Because the regression model reveals who actually spends the most, and the answers are completely counterintuitive. Let's start with gender.
The data shows a statistical divergence based on the patient's sex. Male patients actually drive higher costs.
Really?
Yeah. Specifically, a male patient raises direct costs by 0.2% and indirect costs by 5.6% compared to female patients.
A 5.6% jump in indirect costs just for being male? What is driving that? Is it a biological difference in how the disease presents, or is it a societal thing?
Well, the literature indicates it is a mix of both. Biologically, some studies suggest male SCD patients can experience higher frequencies of certain severe complications.
Okay, so more hospital time.
Right. But societally, in many households, if an adult male breadwinner is incapacitated by a pain crisis, the lost income, that presenteeism and absenteeism we discussed earlier, registers as a much larger indirect financial hit to the family's total resources in the model.
That is fascinating. But the next predictor really threw me. Age.
Ah, yes.
Logically, if you have a chronic disease that systematically damages your internal organs over time, you would assume that the older you get, the more expensive you are to care for.
Yeah.
Your body has simply endured more wear and tear.
It makes total sense on paper.
Right. But the data says the exact opposite. Older patients cost less.
It definitely seems backward at first glance. However, when we look at the clinical trajectory of SCD, there are two vital factors at play here. First, as patients mature, their immune systems become slightly more robust against certain pediatric infections.
Oh, that makes sense. In childhood, a simple fever can be a life-threatening emergency requiring immediate, expensive hospitalization.
Exactly. And the second factor is behavioral adaptation.
What do you mean?
Older patients often develop better self-care routines. They learn to identify their specific triggers for a vaso-occlusive crisis. Maybe they realize dehydration sets it off, or extreme temperature changes, or overexertion.
So they know how to avoid the crisis in the first place.
Yeah, by actively managing those triggers, they require fewer emergency room visits and, according to earlier studies, fewer blood transfusions. They become experts in managing their own bodies.
They basically figure out how to run the shadow hospital more efficiently.
Exactly.
Okay, I follow that. But I am still struggling with the data on location and income. The regression showed that urban patients have higher costs, 0.7% more in direct costs and 0.2% more in indirect costs. And the real kicker, higher income households spend significantly more on care than poorer households. Wait, isn't it wild that having more money or living in a city with better hospitals actually makes the economic impact look worse in the data?
It sounds totally contradictory.
If I have the capital to buy good food, or I live right next door to the Greater Accra Regional Hospital, shouldn't my health outcomes be better and therefore cheaper?
What's fascinating here is we have to distinguish between the severity of the illness and the actual expenditure being measured. The data is measuring money spent, not necessarily how sick the patient feels. Urban and wealthier families aren't inherently suffering more complications. They simply have the physical access and the financial capital to actually pay for the expensive necessary treatments.
Oh, I see. So if my child has a severe pain crisis and I have the money, I hail a taxi, I go to the hospital, I pay for the lab tests, and I purchase the safe blood for a transfusion.
Right.
My recorded costs are extremely high because I am actively participating in the formal healthcare system.
That is exactly the mechanism. Conversely, imagine a rural or poorer family facing the exact same pain crisis.
Yeah.
They might not be able to afford the transport, let alone the out-of-pocket costs at the clinic. They might be forced to endure the crisis at home or seek cheaper, less effective alternative treatments.
So their cost on paper within the regression model is technically lower.
Yes, but that absence of expenditure does not mean an absence of suffering. In fact, spending less in this context is almost certainly at a great detriment to the patient's health and life expectancy.
Wow.
The lower cost isn't a sign of efficiency. It is a devastating symptom of restricted access to quality healthcare.
That completely reframes how we have to look at health economics. We can't just aim for lower expenditure across the board because the highest numbers aren't always the worst case scenarios.
Yep.
Sometimes the highest numbers belong to the only families actually receiving the full standard of care to stay alive.
Which leads directly to the overarching conclusion of the manuscript. When the baseline cost of adequate care is a mathematical impossibility for the average family, a reactive healthcare system, waiting for the crisis to happen and then trying to pay for it, is just a path to financial ruin.
The researchers emphasize that early detection is the absolute key here, specifically neonatal screening, testing babies the moment they are born.
It is vital. It doesn't just save lives by allowing doctors to prescribe preventative antibiotics and avert those early deadly childhood infections. It gives families foresight.
It allows them to see the financial train coming down the tracks.
Exactly.
Instead of being blindsided by a catastrophic medical bill 5 years later, they have the runway to plan, to adjust their economic strategy, and to prepare for a lifetime of healthcare demands.
It changes the family from victims of a sudden financial shockwave into active managers of a chronic condition.
And this is why this matters to you, the listener. You don't have to be a health economist or a geneticist to care about this. If you care about human resilience, this study is a stark reminder that we cannot look at a disease merely as a clinical issue.
Absolutely not.
A medical diagnosis is fundamentally an economic event. It alters the financial trajectory of a family, a community, and by extension, an entire nation.
I want to leave you with a final thought to mull over. The manuscript references the dawn of new treatments. Currently, stem cell transplants are the only potentially curative intervention, though they are incredibly risky.
Right.
But new definitive gene therapies are on the horizon. Genetic cures are coming.
The ultimate breakthrough.
Yes. But these cures have massive, multi-million-dollar upfront costs. The promise is that a one-time cure will dramatically reduce that downstream economic burden we just spent all this time discussing.
All those decades of shadow hospitals, lost wages, and hospital visits.
Right.
You pay a fortune today to save a fortune over the next 50 years.
But consider this. If a lifetime of simply managing the disease on a daily basis already bankrupts an average family, how will our global healthcare systems calculate the value of a multi-million-dollar upfront cure?
Whoa.
Yeah. Who will have the capital to afford the cure and who will be left managing the symptoms? Will the ultimate breakthrough for sickle cell disease be a medical triumph, or will it have to be an economic revolution?
That is a heavy but deeply necessary question. It shows when the foundation of a family's livelihood is at stake, you can't just offer a medical fix without addressing the financial reality. Thank you so much for joining us on this deep dive. Keep questioning the world around you, keep looking beneath the surface, and we'll see you next time.